10 signs of autism for a child 18 months or older. 1 in every 68 children are affected by autism. Did you know autism is treatable? Doctors agree that early intervention is critical. Every month that passes without treatment slows progress. When you point at something for a child to look at, a child's typical response will be to look in the direction you are pointing. A warning sign may be a child's inability or desire to look in that direction. Children often point to communicate their wants and needs. A warning sign may be if a child is unable to point, but hand leads or resorts to inappropriate behavior to get their needs met. When you call a child's name, they usually come or reply to let you know they heard you. If your child does not respond when you call them, possibly appearing in their own world, this may be a warning sign. Making eye contact when interacting with someone is a natural response. A warning sign could be a child's lack of eye contact. In fact, they may even avoid looking in the direction of a person talking to them altogether, preferring to look at the ground or turn away. This is especially evident with people outside the family. When given a simple direction like "get your cup," most children will quickly do what they are asked. A warning sign may be if a child is having difficulty following simple directions, often appearing as if they didn't hear or understand you. If you approach a child to pick them up, a typical response is the child will raise their arms up. A warning sign can be if a child does not raise their arms to be picked up. They may even seem unaware of your intention to pick them up. Playing with toys appropriately is natural for most children. If a child would rather line up their toys than play with them, this may be a warning sign. Most children look and explore items in front of them from a forward-facing viewpoint. A warning sign may be a child's prolonged viewing of a toy from the side, out of the corner of their eyes. Children often act silly, spinning, flapping, and walking on their toes just for fun and to explore the sensations. However, it may be a warning sign if done often, repetitively, and appears hard for them to stop when directed to. Most children enjoy playing or interacting with others. A warning sign may be a child who shies away from engaging with others, often appearing disconnected from those around them. If many of these atypical actions seem familiar, it is recommended that your child be screened by a local specialist. Your child may have a developmental delay that can be easily treatable. However, there is no need to wait for a diagnosis in order to start Gemini. Gemini offers scientifically proven, effective online therapy that you can enjoy in the privacy of your home. It's never too late to start. Children of all ages can benefit from Gemini.
So these are the common signs in which here it was shown in comparison with the normal Hello?
Yes.
Yeah, we will continue now. So we saw all the signs. We will just, when we are reading, we'll just recall ourselves the signs we saw in the child and how these are the signs which symptoms or signs will be given in the exam, that there won't be eye contact and the child will not respond to you, and the child will not play with you, will refuse to play with you, or not looking at you, not responding to you, playing in one toy continuously, doing one action continuously, instead of playing with the toys, like it was shown in the picture very clear that a girl was playing with some fruits or something. Instead of playing naturally, they start lining up things and they start just seeing from the corner of the eyes. They don't look at you. When they need anything, they will not point at it, they will take your hand to it. So all these are the signs. It was very clear, like how a normal child does and how an autistic child does. If you have observed in the video, you can go back and check again the same video so that you'll get the idea, like 10 signs of autism. So now we will, when we are reading, we can correlate these signs to ourselves. So approach to developmental assessment to autistic child. Autism is defined as neurodevelopmental delay, mainly of language and social areas. So you will have developmental delay mainly in language and the social areas. So there is some triad. One is the abnormal social interaction, abnormal verbal communication, and repetitive and inflexible behavior. All these things we saw in the video. When we read it, we can get to know. So what abnormal social interaction we see? At least need at least two or more of the following. So difficulty using non-speech behavior for social interaction, like non-verbal, what we call it as lack of eye contact, limited use of gesture or facial expression with interaction to others. Do not point to indicate their needs, like it was shown in the video, that if the child wants the glass, he was not pointing. Instead, they will catch your hand and take it to the glass like this. Do not point to indicate their needs, limited use of gesture or facial expression, lack of eye contact. Then failure to develop peer relationship, will not develop friendship, will be alone. Lack of spontaneous seeking to share enjoyment. So they will not share the enjoyment, interests, or achievement with others. Like if drawing something, not showing picture to his or mom, like they do something, they will not ask their parents to see for appreciation. Or if the mother is hurt, like lack of social or emotional response. If someone get hurt, patient with autism may not notice. You're hurt, you're crying, they may not notice. They may be indulged in their own play. So all these things you see in abnormal social interaction. Lack of eye contact, no lack of facial expression, and when they interact with others, there won't be any facial expression. Do not point or indicate to their needs. No friendship, they prefer to stay alone. No spontaneous seeking to share enjoyment, interest, or achievement. And there will be, even if someone is hurt, there is no response. And also sensory, they will have sensory processing disorders also, so they may not want to be kissed or cuddled. Just 1 second, we'll continue. So what's the abnormality in verbal communication? This was social interaction. All we read was. Now next is the verbal communication. Delay or lack of spoken language means they will not speak or it is delayed. Patient not responding to question or using few words sentence. Okay, like for example, a three years old child is able to speak only 5 words. Okay, this is speech delay. Usually you see delay in speech and lack of spoken language and not responding to questions. So no expressive speech. Difficulties with starting or continuing conversation. They may have echolalia. This we should know. Echolalia is common, which is either immediate or delayed. So echolalia is common with either immediate or delayed. Immediate echolalia like repeat questions instead of answering. Delay echolalia may take like may repeat words from TV, show referred as videotape talk. So something they are watching in the TV, they will start repeating the same word again and again. Then poor imagination, lack of make believe play or social imaginative play means the imaginative play what we see in children may not see in these children. Like imagining they are talking to their father and playing in the mobile or holding something else and imagining it as a mobile and talking like this we will not see in them. So they may have poor imagination and echolalia, that is repetition of words, and also there is some other word for sentences. I don't know what is called for repetition of sentences. Anyone knows? We can go back and check what we call it as. So there can be repetition of words or sentences instead of asking to your questions, and a poor imagination. Next is repetitive and inflexible behavior. So one is the they love the same routine, they love the same thing to be done. Rigid following of non-function routines, that is sitting in same chair. They want to sit in the same chair. If someone else sits, they may not tolerate it. Obsessions with inflexible and limited interests. They keep on talking about one topic. Obsessions with parts of objects. Focus on wheels of the cars instead of car itself. Instead of focusing on the car itself as a whole, they may just focus on the wheels of the car. Inflexible and repetitive body movements in many ways. Okay, like banging their head or flapping hands, anything you can see, repetitive movements, or some child just keeping on rounding like this. Body movements, jumping in place. Visual, such as eye gazing, looking by corner of the eyes. We saw this in the video. The child was keeping the head on the table and looking from the corner of the eyes to the toy continuous. They may not give clear eye-to-eye contact. They may look from the corner of the eyes. Auditory, making sound and noises in order to hear them. Oral, may play with their saliva. Tactile, may have favor material to touch. Smell, pick up items and smell it before playing. So they may have something called also they may have preferences to particular food, preferences to particular smell, dress, all these things. So specific behavior may be seen like head banging, rocking, wetting and soiling, impulsivity, tantrums, over and under activity. It can be over and under also. The activity can be over, like hyperactivity, and also under. They may show tantrums. They may show impulsivity, wetting and soiling, head banging, rocking, same specific behavior you can see. Also, he dislikes loud noises and crowded places. Okay, this is also known as sensory processing disorder, means they have excessive response to the senses, means some small noises they may not tolerate, or they don't like crowded places, like this. So how, when in the exam, how do you examine? If you think that by the opening statement, this is autism child. Okay, suggested scheme for examination of a child with autism. General measures: shake the hand with the examiner. So you will just introduce yourself to the examiner. Then examiner will give you a vague task like Moheb is 5 years old, please assess his development. So they may just tell you, this is old book, okay, it is not like the present new, but we will just know what are the presentations in an autistic child in the examination part. Okay, because now we have to take history and examination both. Introduce yourself to parents, collect tools. What do you usually collect? Toys and the ball. Next, observe what the child is doing. The first thing you should always tell in the development station before starting the developmental examination, I will observe what the child is doing. This is very important. So you will observe. The child may stay in the corner alone, hyperactive, lack of attention or concentration, doing repetitive behaviors like flapping hands, winning, lack of eye contact, are he in nappies, lack of stranger awareness. You will just observe all these things. You may not find all these things in one child. Maybe when you are seeing the child, observing the child is continuously doing hand flapping movements. This may give you some idea. Next, when you call the child, no response. That means he don't know that someone is around him. Lack of stranger awareness. He is not aware. For some children who have already developed stranger awareness, if somebody is around them who is strange to them, they will be alert or they will run away. They don't want to stay there. You don't see this behavior in these children. And when you call them, there won't be any eye contact. Before that, they may be showing, like when you see them, they are playing in one toy. When you call, no response. Even if the mother calls, no response, you may see that he's doing flapping of hand and sitting in the corner. Whatever you see, you have to tell what you are seeing in the child. Next, assessment of speech and social. So for that, you will make rapport with the child by asking. So you'll start after observation of what child is doing, you will start asking the questions now. So what are the questions? So you're trying to build the rapport and he will not respond to you. Child is not shaking hands, not responding to all these questions. I don't know what's written here. I think what is your name? And what we start with speech and language always. What is your name? What is your age? You are a boy or a girl? I don't know this. So like this, what?
How are you? The last one, Dr. Noor, the last one, ازيك يا محب? How are you?
Okay, how are you? Okay. So I can understand some part of Arabic. So this is what is your name? This is what is your age? This is you're a boy or a girl. And this is how are you? Okay, so you're trying to build a rapport with him by asking questions, but he is not responding to all the questions. He is ignoring. And he will not respond to you, and also he will have delay and lack of spoken language, that is expressive speech and delay in speech. Failure to use facial expression and gesture to communicate. So as we all know, when there is some happy news, there should be a smiling face. When there is something sad happened, you should have a sad crying face. You don't see this facial expression or gestures in these patients. So assess concentration. Then you will start asking some questions like in the speech and language. What is this color? He did not respond to you. Where is red color? Maybe he may not respond to this also. This is receptive speech. Okay. Assess recognition of objects. As we had discussed this, like what is this? This is a duck. If they don't respond, is this, where is the duck? Or can you show me the duck, like this? So they may not do it for you. So assess play. So you'll start for social examination, start to play with him and try to engage. You will be trying everything, but you will fail. They will not come and respond to you. In fact, they will not respond to mother also if she calls. Failure to engage, failure to getting their attention or share play with others. This is social. Failure to pretend play and does not show any imagination. There won't be any pretend play and any imagination. Okay. So you see all these things. So you will fail. It means you cannot engage him. You will fail in engaging him. Then ask mother some questions. After taking permission from the examiner to continue assessing communication. So after you think that he is not responding to anything, you will ask the examiner that you want to know from the mother what all he is doing with the child. Okay. So what you see, lack of delay or delay of speech, find way of meeting their needs other than pointing. This we saw in the video. Instead of pointing to the glass, the child will take your hand to the glass. Okay. Finds way of meeting their needs other than pointing, not pointing. You see delayed speech, limited content in the speech. Like for example, as I told you before, a 3 years old still having only 5 words, failure of toilet training, repetitive behavior, dislike crowded places, upset by minor changes in routine. Ask the mother, take from him his toy. See the anger response, but you will not do it in the exam. But whenever, if their favorite toy is taken, they may get too much upset, shout, anger, tantrums, all these things you see. So presentation of case, Moheb is 5 years old. On entering the room, the most striking observation was that he did not appear to notice that we were there. He did not establish eye contact, and I could not engage him in any play activity. I noticed that he is still wearing nappies. 5 years old, usually they should be dry by day and night both. So he's still in nappies. These features suggest marked delay in social skills. So what he said, that no stranger awareness, did not establish eye contact, and did not engage in play, still wearing nappies. So all this is delayed in social skills. He was vocalizing but did not have any easy recognizable words. Ignoring us. He was talking something, but still you don't understand what he's talking. And his mother reports that he indicates what he wants by taking her hand and putting it on the object he's interested in. He had very little facial expression. This suggests delay in communication skills. Means he speaks which we don't understand, or he speaks very few words, and for his needs he will not tell that I want to drink, or he will not point also, he will take her hand. And very little facial expression, no response to hurts, no response to happiness. In addition to this, mother describes he has several rituals and repetitive behaviors, and he becomes very anxious and has tantrums when there are small deviations from these rituals. Means routines. If there is deviation from routines, they become angry, anxious, shouting, and their repetitive behaviors. And also, you should not take away their toys. These features would be keeping in diagnosis of autism. Developmental team assessment, hearing assessment to exclude impaired hearing, because they will have speech delay, but still you have to do the hearing assessment to be sure if no component of conductive or sensory hearing loss in them. Ophthalmological assessment to rule out visual impairment. Chromosomal assessment, because it can be associated with Rett syndrome, Fragile X syndrome, Angelman syndrome, tuberous sclerosis, and NF1. So you can have some genetic testing also when you suspect some genetic conditions in these children may be associated with Rett syndrome, Fragile X syndrome, Angelman, tuberous sclerosis, and NF1. Metabolic screening, amino aciduria, homocystinuria, phenylketonuria, serum lead level for lead toxicity, CBC, iron, thyroid functions, EEG if epilepsy. So depending upon your case, you will tell. Not in every case you will tell everything, but important here will be the assessment by the developmental team to come to the diagnosis of autism. And you have to be sure that the child has no hearing problems. So management plan will be multidisciplinary approach. Behavioral therapist, occupational therapist, speech and language therapist, social worker or the social support groups, then educational psychologist and also psychiatrist if needed, then educational consideration. So you can have educational healthcare plan here. Then if any financially, if the parents have problem, they may need some financial support because they may have problems in education and they may need special need care for education. I don't know what is the new treatment. So how the case can come, we'll just go through. For example, Andrew is a 3-year-old boy with a family history of autism. They can also have family history in a child. 1 or 2 children can be autism. So family history of autism. On entering the room, 1 o'clock. On entering the room, the most striking observation was that he did not appear to notice that we are there. He did not react with any stranger anxiety or interest, as is commonly seen in 3-year-old boys. He did not establish eye contact with anyone in the room, including his mother. He was constantly trying to turn light switch on and off. So they may also hold something or go to some place and start doing the same thing again and again. By your observation in this child, you just saw him turning light switch on and off and showed no interest in the toys available. He's not playing in other toys, just doing this. I was unable to engage him in any play activity and he became distressed when his mother tried to move him away from the light switch. So he was vocalizing but did not have any easily recognizable words, and his mother reports he indicates what he wants by taking her hand and putting it on the object he is interested in, such as the fridge or the television. He had very little facial expression. The delay in social and communication skills was out of proportion to his motor development. This is one more thing you see in these children, that they are more backward in speech and social compared to gross motor and fine motor. So it is out of proportion. The delay in social and communication skills was out of proportion to his motor development. I was unable to engage him in any formal assessment of these today. So he could not engage. So this will be your final presentation. I was unable to engage him in any formal assessment of these today. However, I observed him walking, running, and he was able to move a chair or climb on it. These features would be in keeping with a diagnosis of autism. In addition to this, mother describes some behavioral traits that are typical to the children with autistic spectrum disorders. In particular, he has several rituals around dressing and washing. He becomes very anxious and distressed when there are small deviations from these rituals. Based on these findings, I would agree that a referral to autism assessment is indicated. So you will list, when you are presenting a case at the last, you will list all your points and say that you were not able to engage him in the assessment, but you, on observing, he was playing continuously with the light switch and no response to you and no response to the mother. But then on asking the mother, you will say all these things. She sees some repetitive behaviors in him, like banging of head or flapping hands, continuous. Whatever mother gives the history, you will note it down and you will say like this. And he starts lining up the toys. He will not interact with people, and he gets distressed when his toys are taken, or some when he is deviated from his routines. All this history you will take from the mother and present the same thing at the last. Okay, someone has posted that repeating words is echolalia and repeating sentences is scripting. It's in chats. Okay, scripting. SCREPTING. This is one more video. We'll just go to see, and then we will only go about the details of diagnosis and management. Then we'll finish with autism. Okay. See here, it's written. Alistair seems to be a typical happy, healthy boy, but look a little closer, you will find.
Big kid.
See, this is hand flapping. Okay.
Everyone, this is Alistair's dad. The most important thing to remember is just because some of these signs exist in your child, that doesn't mean an automatic diagnosis for autism. However, the more these behaviors occur in your child, the more concerned you should be. The key here is consistency and frequency of these behaviors. So in this
So what he said, the consistency and frequency, this hand flapping, you can see, he keeps doing now and then.
first example, it's pretty obvious. Some children will hand flap during early development, but as with all these signs, pay attention to how long the behaviors last. If the child grows out of these behaviors, generally around 3 years of age, there's not much to worry about. But with someone like Alistair, who hand flaps every day, there is cause for concern. This is one example of self-stimulation, or stimming as it is called, and it helps to calm children with autism. This second example can be confusing to some, as most people have at least attempted to walk on their tippy toes at some point in their life. Again, pay attention to how often the child does the behavior. Our 9-year-old son, who was diagnosed with autism, still walks on his tippy toes to this very day.
See, he's telling still a 9 years old is walking on tiptoes. Small children, okay, but if this walking on tiptoes continues, it needs evaluation.
This third example may seem alarming. However, as long as they bang their head on something soft, like this padded high chair, generally they'll be okay. As a form of stimming, it can help calm the child due to the rocking motion. Many people with autism like to rock back and forth. We also show Alistair banging his head on the glass door and on the ground to show you different examples. However, after recording the footage, we promptly removed Alistair from the situation and redirected his attention to avoid any potential damage. Some people even need to buy football helmets for their kids, it gets so bad. This fourth example may not seem so odd to parents and others. After all, hasn't every kid been fussy in public at some point? But this behavior has less to do with not getting a treat or a toy, but due to the loud, bright conditions of most public settings. While it may be hard to distinguish sensory fussiness or meltdowns from common temper tantrums, an easy way to tell is this. When you give your child what they want, do they stop the bad behavior? If so, it's probably them just throwing a typical tantrum. However, if they continue to fuss, scream, and cry as if in pain, even after they get what they want, then it's probably a sensory-related tantrum or meltdown, as most people call it. Although I don't recommend giving into a child's demands, I think this exception can help once in a while, as it can be very revealing. Also, most common tantrums last minutes, whereas a sensory meltdown can last hours. Oh, buddy, I love you. Hard time, I know. We'll get you home, okay? In this fifth example, we see another example of stimming. While every child loves to play with water and blow bubbles in their milk, the key here is, again, how long does this behavior last? Also, you may notice that your child is doing this behavior alone, withdrawn from others, instead of trying to put on a show. Generally, the behavior will last longer than 5 or 10 minutes and can last hours depending on the severity of autism. Look for extreme obsession and repetition with objects. And number 6, we have very aggressive behavior. All kids fight at some point. But is your child doing this immediately after being punished, as if they are enjoying it? It may seem odd, but this can be another form of stimulation, as they get a strong response from others when they are aggressive. You will notice the child being much more aggressive than a typical child for no obvious or good reason, like wanting something another child has, such as a toy. Alistair, can you use your words? What do you think about the car wash? At number 7, we have a lack of response to voice or sound. While every child has ignored their parents at some point, usually out of spite, you will notice an autistic child being aloof, as if in their own little world. Sometimes parents think their little child has hearing problems at first, but this has more to do with being withdrawn than not hearing. If anything, autistic people hear too much and have a hard time filtering out noises. Alistair, what are you playing with there, bud? You playing with a car? Sit down. Alistair. 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 Alistair, I'm talking to you. Number 8 is probably the most well-known sign, and that's the lack of eye contact. Most people with autism will avoid eye contact whenever they can, and many describe it as painful. While the specific reasons can vary from person to person, this is definitely a strong sign that autism is present and usually persists into adulthood. Number 9 is missing speech milestones. If you don't know the general rule for how many words your baby or toddler should be using, then it's only a quick internet search away. Generally, if your child is only using a few words at age 3, there is cause for concern. If your child is 4 or 5 and is still not using basic sentences, there is a great cause for concern. Also, echoing words or echolalia is when they constantly repeat the same phrase, not in a learning way, but more like a broken record way, again and again and again. So be aware of that too. It's been saying the same thing for the past 20 minutes, right? Finally, not all people with autism are nonverbal. Just because your child may be talking doesn't mean they're necessarily out of the woods. Number 10 has to do with problems in food or textures. Many people with autism are picky eaters, which ties in with the sensory issues. Some hate the feeling of yogurt or dislike their food touching other food. While this sounds like typical child behavior, it's on a much higher level. If you offer that food to your child, even if they are clearly hungry, they won't eat it even to save their lives. Fortunately, our son Alistair passes this test mostly. He loves all kinds of foods. He is much more picky with textures like clothing tags and scratchy shirts. Our older boys who have been diagnosed with autism still love to wear their clothes inside out to avoid clothing tags or odd textures. Alistair loves the feel of flannel and likes to wear hats for the feeling of security it gives him. While we didn't get to cover all the signs and symptoms of autism, we hope this gets you started in the right direction. If you seriously think someone you love has autism, please reach out to a local psychologist, neurologist, social worker, or other professional. The sooner you get your child help, the greater chance they will have adapting to society and its many social customs. On that same token, please continue to help those with autism by educating yourself and others about the conditions they face every day. Thanks for your time and best wishes.
So we again saw in this video also, there was flapping hands, there was lack of eye contact, echolalia, the child was repeating one word, and he was constantly playing with the same toy. So what are the differential diagnoses for autism? It can be neurodevelopmental disorders, example, specific language delay or disorder, that is speech delay or disorders causing the speech delay, learning difficulties or disability, and global developmental delay. Then they can have mental health and behavioral disorders also. ADHD and autism can come together in some children. Next is condition with developmental regressions. We should know what are the conditions with developmental regressions. One is the Rett syndrome, then epileptic encephalopathy and childhood disintegrative disorders. Then some children who may have very poor speech only because of severe hearing impairment. That's why you should always screen out these in case of autistic children, also the hearing impairment and also the visual impairment and selective mutism. Okay, these are the differential diagnoses you can give. Conditions with developmental regression, severe hearing impairment, visual impairment, selective mutism, and neurodevelopmental disorders and behavioral disorders. If the ASD is associated with developmental delay, learning difficulties, there you may have difficulty in diagnosis. So what do you do for diagnosis of autism? How do you make the diagnosis? This is very important. Diagnosis and management will be asked in the exam. So making the diagnosis, the condition can reliably diagnosed between 2 to 3 years of age. If you're this is the early, you can diagnose by the age of 2 to 3 years. NICE has published guidance for assessment and referral for children with suspected autism. We saw all these signs: lack of eye contact, lack of communication, lack of stranger anxiety, at 3 years saying very few words, echolalia, repetitive behaviors, tantrums for changes in routine, doesn't like some texture of the clothes, food, all these things. If you suspect any child with autism, you will refer. Okay, so NICE has published guidance for assessment and referral of children with suspected autism. So where do you refer? Whom do you refer to for diagnosis? So specialist diagnosis is required. This is probably best done by pediatric neurologist, developmental and behavioral pediatrician, child psychiatrist or psychologist. So it will not be one person, it will be a evaluation by a team. It will not be one person evaluation. So what do you say? There is an ASD team. You will refer them to the ASD team. Okay. So ideally, there should be a multidisciplinary team approach, that is the ASD team, with specific training and experience in evaluating the children with ASD. So what is, whenever you suspect that the child has ASD, you will refer for specialist diagnosis to the ASD team. Okay. So what does the ASD team consists of? This is the pediatric neurologist, the developmental and the behavioral pediatrician, and the child psychiatrist and the psychologist, both. So you can, all together they form an ASD team. So because it is associated with neurodevelopmental disorders as well, so a pediatric neurologist evaluation is very important. And maybe the child is normal, just has behavioral problem, he does not has other things. So the developmental and behavioral pediatrician is very important. Because of their tantrums and all these things, psychiatrist, psychologist is very important. So they all together form ASD. This is for the diagnosis. So a specialist diagnosis is made and the child will be referred to the ASD team. Then involvement of speech and language and occupational therapists, special educators and social worker may provide a more detailed assessment of specific domains. So once you refer to ASD team, it will be evaluated by all the specialities, and also speech and language, occupational, social worker and special educators will also be involved. So whenever you suspect that it is associated with some other conditions, you may do what? Chromosomal analysis. Okay. We read there that it may be associated with Fragile X syndrome, Rett syndrome, tuberous sclerosis, NF1. So they may need the genetic testing sometimes. Okay. Other conditions need to be excluded and investigations for chromosomal analysis, hearing and sight assessment. So complete hearing assessment and complete visual assessment are usually taken prior to reaching the diagnosis. So you should rule out all the differentials what we read before, like the hearing problems, the vision problems has to be ruled out. And also if they are associated with any chromosomal disorders or genetic conditions, so if they need, you have to run these investigations. When clinically relevant, the following should be considered for all children and young people with ASD. So you have to do the complete examination of the child to see if he has any neurocutaneous syndromes, or he has any dysmorphic features and going with some genetic syndromes. So you will examine what the physical status of the child with particular attention to neurological and dysmorphic features like Fragile X syndrome or Rett syndrome. And even sometimes you can see behavioral problems in some other syndromes also, like Williams also. So you need to do the complete physical examination. Then karyotyping and Fragile X DNA analysis in boys. You may need it, Fragile X DNA analysis and karyotyping. Here, complete hearing examination, investigations to rule out recognized causes of ASD. As I told you, neurocutaneous syndromes are more common. So you have to examine the skin if you see any neurocutaneous stigmata in the skin. And also if you suspect, you can investigate for it. So investigations to rule out recognized causes of ASD like tuberous sclerosis, complete hearing examination and assessment, karyotyping, Fragile X DNA, and complete neurological and dysmorphic examination. You have to do head to toe to know the cause. Assessment of children and young people for ASD cannot be rushed. You cannot give by just examining the child once that he has ASD. He has to be followed up by the ASD team and they will search for the criteria. It may not be possible to obtain sufficient evidence in one session, and the child and young person may require observation in different settings. Example, at school, especially in uninstructed activities such as break time, as well as at the clinic. So how is he at school? How is he at home? How is he when he is coming to your clinic? Everything will be observed. So, and also is diagnosed when an individual exhibits 6 or more symptoms across the 3 core areas. So the 3 core areas we read before, that is the social, communication, non-verbal, verbal, and repetitive behaviors. 3 things: non-verbal, verbal, and repetitive behaviors. In these 3 areas, they should have 6 or more symptoms. So all these things, details are not needed. For us, the diagnosis will be by referring to the ASD team, which will be a group of pediatric neurologist, psychologist, psychiatrist, and a pediatrician specialized in autism. Okay. And apart from that, they should be assessed for what? All children and young people with ASD should have comprehensive assessment for their speech and language and communication skill. So this will help to decide which interventions are best suited for their child. So you should refer to ASD team. Referring children and young people to ASD team, early assessment and diagnosis and intervention are very important. Indication for specialist referral for further assessment include. So early diagnosis, assessment, diagnosis, and intervention will help these children a lot. So when a child younger than 3 years has regression in language or social skill, you will refer to ASD team. Or there is another way, refer first to pediatrician or pediatric neurologist who can refer to ASD team if necessary. Children and young people older than 3 years with regression in language, or for any age with regression in motor skills. Okay, so whenever you see a child with regression, you can refer to ASD team for evaluation. So when you will refer directly to ASD team if you are concerned about possible ASD on the basis of reported signs. Okay, reported and observed signs, to take into account of severity and duration of signs and symptoms, extent to which signs or symptoms present across different settings. That is, how long they have these signs and symptoms, and how are these signs and symptoms at home and school. Impact of signs or symptoms on child and young person on their family. Level of parental and carer concern if appropriate. Okay, so all these things. For us, no need to go into details. We just should know that we will refer to the ASD team if all these symptoms are there. If they ask in detail, then only we have to go, but there won't be any time. It will be just 3 minutes discussion. So just we should say referral to ASD team. So what is the management? Early diagnosis and appropriate intervention. So this is very important. Early diagnosis and appropriate intervention. What is the intervention? They will have specialized educational programs and structured support. Okay, so specialized educational programs will be there and structured support may be given. And also their environment and negative impact should be minimized. Care should be taken into account the physical environment and negative impact. Okay, all these things is not needed. So what are the helps you will give? Like psychosocial interventions such as play-based strategies with parents, carers, and teachers to increase attention, engagement, and reciprocal communication. So the parents should also be given classes to cope up with these children. So all these individual you can go through later. So how do you intervene with the communication? And occupational therapy, how the occupational therapy will help these children? They will give something called sensory integration therapy, the occupational therapy. Okay, sensory integration therapy has been used when there are marked sensory perception issues. Example, oversensitivity to touch. Okay, occupational therapist desensitizes the child gently over time. So when they have this sensory processing disorder where they don't like to wear a particular kind of dress or eat particular food or smell all these things, so they will give sensory integration therapy for their oversensitive issues, and gently over time they will desensitize. And the other things they take care is the fine motor skills. Okay, and the adaptive environments, that is home adaptations. So all these are the help, but mainly we should know the support, what we should give for the ASD team and how they will be managed. Okay, just go through and make the important points from here. It's very important. And also interventions for coexisting problems. You can also consider group or individual cognitive behavioral therapy for these children. Okay, group or individual cognitive therapy for anxiety if person has verbal and cognitive ability to engage in intervention. So all these things, just heading can be made. They may have sleep problems as well. Okay, and assessment of that should be done. And also they can have obstructive sleep apnea. So a sleep plan, develop a sleep plan. So in your history, you should also ask about sleep in these children. Okay. Feeding problems, restricted diets, all these you can hear. So transition to adult service, we know it. Adults is not needed. Next, prognosis. The outlook for many people with ASD is now much better than it was 50 years ago, with more affected people able to speak, read, and live in community rather than in institutions. Some will be largely free from symptoms by adulthood. However, most affected individuals are unable to work full-time or live independently. But it is better because of the improved level of the support given to them. It is better than before. So what is this finally? It's a lifelong disorder and has great impact on child and young person and their family or carers. So they will have impact on everyone's life. So social history becomes very important here. ASD varies great in terms of level of impairments which influence the prognosis. A minority of affected people with lower level of impairment live and work independently. So some can live and work independently, but most of them cannot. So this is very important point for us out of all these things. The prognosis of ASD can be improved by early diagnosis and intervention and assessment. Early diagnosis and assessment with provision of support and services in education, health services, social care, and voluntary organization in contact with other families with similar experience. So by giving them good support for education, health service, social care, and also you can involve the support groups, that is the voluntary organizations, and contact with other families with similar experiences. All this together will give you good prognosis. Early diagnosis, intervention, early diagnosis and assessment and intervention, and giving good support to education. So they should have good educational healthcare plan and good social service support, social care, social supports like voluntary organizations, and they should be in contact with other families with similar experiences. All these things will give a good. So we are done with autism.
At school, other ADHD may be to blame for their symptoms. Step 5. Gauge the seriousness of the problem. Children with ADHD are regularly disruptive at school and at home. Their behavior causes problems in their relationships with both adults and other children. Step 5. Gauge the...
So like this, you can have a checklist can be given, and the mothers can make a list of the problems, what they observe in home, and they can write it.
Seriousness of the problem. Children with ADHD.
Yeah, it's given. Like here, what is here? It's written here. My child does not complete tasks or jobs that I give him to do. She gives the scoring here. My child does not listen to me or does not pay attention to me when I am talking. My child daydreams a lot. It seems that we are always looking for things that my child has misplaced. Like this, my child has poor concentration on tasks that are difficult, hard, and boring. And now the mother keeps on recording it and gives her assessment.
Children with ADHD are regularly disruptive at school and at home.
They are regularly disruptive at school and at home.
Behavior causes problems in their relationships with both adults and other children. Step 6. If you recognize any of these symptoms in your child, take them to your pediatrician.
So when you recognize all these symptoms, they need an assessment. Okay.
It's important that they have a medical checkup to rule out other causes for their behavior.
So even you have to rule out the other causes, like maybe again the neurodevelopmental causes, genetic causes can be related, that has to be ruled out.
Before ADHD is diagnosed. Did you know children whose mothers had smoked while pregnant were more than twice as likely to have ADHD as children whose mothers did not smoke?
So even the smoking history is very important. Children whose mothers have smoked while pregnant, they have twice more likely to have a child with ADHD. So smoking history and pregnancy. is important. Overview of the attention deficit hyperactivity disorder, and the DDs what you can consider, and the diagnosis and management. So ADHD is a persistent pattern of inattention or hyperactivity and or he has written. Okay, they can have together or one thing, inattention or and or hyperactivity, impulsivity that is more frequent and severe than is typically observed in individuals at a comparable level of development, which interferes with functioning and development. Any child can be hyperactive and also inattentive, but it should not go to an extent that it will interfere with function and development. A hyperactivity in a child which is not impairing his function and development, you cannot consider it as attention deficit hyperactivity disorder, because normally all children looks hyperactive, all boys keep running, all boys keep moving here and there. But the thing is, to consider it as attention deficit hyperactivity disorder, you should see that it should interfere with functioning and development, okay, compared to the normal children. They are so much hyperactive and they are so much inattentive that you are speaking, but they are doing something else. They are moving around. In the school, they are not sitting. They are, when the teacher is teaching, but they don't want to sit. They want to get up, jump, run away, like this. Okay. It interferes with the functioning and development. So how do you diagnose? In 2018, guidelines from NICE state that the diagnosis of ADHD and symptoms of hyperactivity, impulsivity, and or inattention should be, how do they do? They have made this criteria for diagnosis that is called DSM-5. That is the Diagnostic and Statistical Manual of Mental Disorders. Even if you don't remember the name, it's okay. Just remember DSM-5 or ICD-10. Okay, they have this classification, DSM-5 and ICD-10. They will check the problems in the child and they will tick. Sorry, there was some problem. So a diagnostic criteria is DSM-5 or ICD-10. Okay. You should know that. How do? There is a checklist. They will check and they will observe the child and then they will decide. So how it is done? Be associated with at least moderate psychological, social, educational, or occupational impairment based on interview or direct observation. A child will be observed in different settings, that is at the school, at the home, or any other place he goes, maybe grandmother's house or any other place he goes. He has to be observed in multiple settings for this hyperactivity, inattentivity, and impulsivity. Okay. So any impairment in this area like educational, occupational, psychological, social, you will consider it. So the DSM-5 diagnostic criteria for ADHD is for inattention. For inattention, there should be 6 or more symptoms of inattention. Okay, in that criteria, they should meet at least 6 or more symptoms of inattention in at least 2 or more settings. Like they should show all these in at home and at school. At least they should have 6 or more symptoms. There is a list of symptoms. Okay, and these are the list here he has mentioned. You can go through later. Okay, what's the list? Because now we are just reading like what we should know to answer in exam. Okay, next is the for hyperactivity and impulsivity. Again, you should you should have 6 or more symptoms of hyperactivity and impulsivity. Okay, for children up to the age of 16 years, and it has been made 5 and more for children aged more than 17 years. Okay, and it should be in more than 2 settings always. Apart from this, six criteria in each. In addition, the following conditions must be met. That is, several inattentive and hyperactivity impulsive symptoms were present before the age of 12 years. Okay. Then several symptoms are present in 2 or more settings. This is very important. He's just doing it at school. Maybe there is some problem in the school, in the environment. He's just doing at home. Maybe there is some problem in the home environment. It should be both at the school, at the home, at some other place he visits on and off, maybe nursery or the grandmother's house, whatever. It should be the activity should be in 2 or more settings, at home, at school, or work, with friends or relatives, or in other activities. There is clear evidence that the symptoms interfere with or reduce the quality of, and also you should know that it should interfere with the routine activities and reduce the quality of social, school, and work functioning. Okay. So this is the diagnosis. You should know about it. No need for epidemiology. Yeah, then what are the causes for ADHD? Okay, the cause is unknown, but there appears to be combination of genetic and environmental factors. Okay, the cause is unknown, but there appears to be genetic and environmental factors. Twin studies demonstrate high inheritability. Those with first degree relative with ADHD are more likely to have the condition. So if you get a case of ADHD in the exam, ask about family history. Okay, because those with first degree relative with ADHD have more likely to have the condition. Next is the as we saw there, maternal smoking or alcohol exposure during pregnancy. This is one of the risks. Low birth weight and preterm delivery is also the risk. Epilepsy like tuberous sclerosis also is associated with ADHD. Acquired brain injury, lead exposure, maternal mental health problems, substance abuse, and neurodevelopmental disorders, and some this oppositional defiant disorders. All these you can say that some mental disorders, also psychological issues can also cause. But more than that, importantly, you have to remember is this, the risk factors, which can include low birth weight, preterm delivery, maternal smoking and alcohol exposure, and any epilepsy or genetic conditions associated with it. Okay. Next is the assessment. So when you suspect, how do you assess this child? So it can be considered in all age groups, not just 6 years, 5 years. No, ADHD should be considered in all age groups. Diagnosis should be mainly made by a specialist psychiatrist, pediatrician, or other healthcare professional with training and expertise in diagnosis of ADHD. As we read there in the before case, we read ASD team. Similarly here for the ADHD also, you will refer for the specialist evaluation, which consists of the specialist psychiatrist and a pediatrician and other healthcare professional, or he should be a specialist psychiatrist or the specialist pediatrician who is expert in ADHD, or any health professional with training and expertise in diagnosis of ADHD. Again, the diagnosis is based on, as we read there is DSM-5 criteria. You will check for 6 criteria in each. A full clinical and psychological assessment. Again, before, not just those criteria, you should also do assessment of the child. So full clinical and psychological assessment, discuss the behavior and symptoms in different domains and settings, a full developmental and psychiatric history and observer's report. I showed you in the video, mother was ticking whether this quality is there in my child or not, whether inattentivity is there. This has to be, the observer will report it. It will be given to them to observe and report over a period of time. So a full development and psychiatric history and observer reports and an assessment of mental state. And also these questionnaires will be given rating scales such as strength and difficulties, and Corner's rating scale may be used with the expertise by those with expertise, and may also be useful for monitoring but should not be used alone. Only this is like this, they will give the questionnaires to the parents, to the school teacher, and also to the grandmother, whoever, and they will be filling the questionnaires that these are there in the child. But this will support the specialist psychiatrist or the specialist pediatrician whom the child will go for assessment. These questionnaires will help them. Okay, but it will not be based diagnosis just on these questionnaires. Along with this, the specialist will do all these things. What he will do, he will do a full clinical psychosocial assessment, head to toe examination, again for neurocutaneous, for neurodevelopmental disorders, and psychiatric history, family history, everything will be taken, and this can support them, the activity of the child. So, and also it should also include, the assessment should also include assessment of the person's needs, coexisting conditions, like any condition he's suffering from. Apart from that, social, familial, and educational, occupational circumstance, and also for children and young people, assessment of their parents and carers' mental health. As we said, it run in families, maybe their parents also had some problems. So and also children's ability to make and keep friends, school achievement, family relationships, ability to eat, self-care, travel independently, ability to avoid common hazards, crossing road safety, etc., emotional state, all these things will be observed. Okay. So what is the differential diagnosis? A number of conditions can have symptoms similar to ADHD, that is thyroid disease, anxiety, depression, bipolar, autistic spectrum disorders. So if they ask DDs, you can give all these things. Even ASD can be given. ASD and ADHD can be together also. And harmful oppositional defiant disorders, conduct disorders, tic disorders. fetal alcohol syndrome. As we read, alcohol and smoking exposure is an this for predisposition for ADHD. So fetal alcohol syndrome. Yeah, sometimes these drugs, children on steroids, antihistamines, anticonvulsants, beta-2 agonists, caffeine, nicotine can have some effects like ADHD and it may mimic. Okay, NICE guidelines notes that girls and women are more likely to be misdiagnosed with another mental health condition or neurodevelopmental disorder, because they think that ADHD is not common in the girls and women, but can come. It can be misdiagnosed. So management, again, management is what? Referral. You will refer to the specialist. So in children and young people, if problems are having an adverse impact on development or family life, so you are suspecting ADHD. At that time, what do? The first step you will do is watchful waiting. This is the first step. Watchful waiting for up to 10 weeks. A watchful waiting will be done for the child up to 10 weeks. That means, suppose your child has been, you are thinking that he has ADHD, you will approach maybe the pediatrician or specialist psychiatrist, whoever. They will first ask you to, they may give you the questionnaire and also ask to watchful waiting and to list these questionnaires during this time. So watchful waiting for up to 10 weeks, because sometimes it can be acute with, if the child is taking some medications also. We read that there are some side effects of the medications. So watchful waiting for up to 10 weeks. If the problems are associated with severe impairment, refer directly to secondary care. So maybe whoever the first doctor you will give, they will tell you to watchful wait for 10 weeks. If there is severe impairment, they will refer you to the next. Okay, just one. Then after first step is watchful waiting for 10 weeks. Then if you observe that the child has problems with severe impairment means he should have problem with regular school work. He's not learning things due to his hyperactivity and impulsivity. So at that time, what you will do? You will refer to secondary care, offering referral to a group-based ADHD focused support. So again, there will be group-based ADHD focused support. This should not wait for a formal diagnosis. Before the diagnosis is done also, a group-based ADHD focused support can be given. So after waitful watching, first step is group-based ADHD support. Then what you will do? Still the problem persists with at least moderate impairment. Here it was severe impairment. Okay, he is not at all doing schoolwork. he's not at all attentive to you, not sitting, not eating, just jumping like this. And then what do? You will do this group-based ADHD focused support. And then if the problems persist with at least moderate impairment, then specialist referral is needed to confirm the diagnosis and start management. So before confirming the diagnosis and management, you will start doing all these things. After wakeful watching, a group-based parental support will be given, in which the parents will have meeting, like how they can improve the condition of their child. After that also still there is moderate impairment in the child, you will refer the child for the diagnosis. Specialist referral is needed to confirm the diagnosis and start management. Referral may be to a specialist pediatrician, a child psychiatrist and CAMHAMS. Okay, so you will refer to either of these people, a specialist pediatrician or a child psychiatrist or CAMHAMS, anywhere can be referred, and they will for diagnosis. So adults presenting with symptoms of ADHD, so no need for adults. We will not go for adults. And this is important point for us. Do not diagnose or start medication. Do not diagnose or start medication for ADHD in children in primary care. No, never. It should be by the specialist, psychiatrist. So what is the general principles of management? What do you do? Parents and affected children need a great deal of explanation and support. Okay. So give people with ADHD and their families written information about self-help, support groups and voluntary organizations as appropriate. So we should start connecting them to support groups and voluntary organizations, and at the same time they should be given to the leaflets about to read themselves how they can help their children. Okay, so these are some of the names of the organizations: National Attention Deficit Disorder Information and Support Service, and this is for the adult, and MIND. What else? Stressing the positive aspects of the diagnosis, assessing help, understanding the issues and symptoms, as well as acknowledge the negative aspects such as stigma. So all these in the group-based trainings, all these will be taught to them. Like for example, discussing the education and employment issues, how they can give the education to their children, how they can help them, and effects on the relationships. All these things will be taught to them in the group based, so we will not go in detail about it. And also these children can also have problems with the foods. So the parents or carers can keep a diary if there are food and drinks that appear to affect behavior. If the diary supports a link between any food and drinks of behavior, you can refer to specialist pediatrician. But this is less common in this compared to this. Okay, now what we read all is the support. Mainly is the support is very important here. And after that, when do you give pharmacological treatment? This is more important, which is not common. Here, the non-medical management is more important. All medications for ADHD should be initiated by the healthcare professionals with training and expertising in diagnosis. So primary care will not start it, only by the specialists it will be started. Okay, this is very important. Medication is usually not recommended for preschool children. Please mute your mic, Dalia. This is the second time I'm muting. Okay, medication is usually not recommended for preschool children with ADHD. No medication. And for whom an ADHD focused group parent training is normally recommended as first line. This is the first line for small children, preschool children. For school age children and young people with ADHD, treatment with medication should be reserved for those with ADHD symptoms causing persistent significant impairment in at least one domain, despite implementation of other management options such as environmental modifications, ADHD focused support, education, parenting strategies, liaison with schools. When all this is already done, like you have ADHD group parenting support, okay, and some environmental modifications is done for the child, still the child has symptoms, then it can be considered. So which is the drug which is most commonly considered is the methylphenidate, is generally offered first line, okay. And if it is contraindicated, then you use these drugs, okay. Just remember methylphenidate, it's more than enough. Before giving methylphenidate, you should check for the pulse, blood pressure, weight and height, and cardiovascular assessment. This is details of medications which will not be asked. Okay. So this is the main management, but there are some more points about tertiary services which you can refer yourself. This is for the ADHD. So it's prayer time here. There's only one topic finish remaining now. But before that, I want to ask, anyone wants to give us any good points about ADHD or autism, can go ahead. No comments? Management.
Suppose that you are a second grade teacher in an elementary school. You notice that Sam, one of your students, speaks differently than the other children in the classroom. Other students appear to have a hard time understanding Sam's speech. You also notice that Sam is easily frustrated whenever he has to do a task that involves talking to others. Based on this information, you conclude that Sam may be suffering from a speech delay. A speech delay refers to when a child does not develop speech capabilities within the normal age range.
So what is speech delay? Speech delay refers to when a child does not develop speech capabilities within the normal age range.
Children with speech delays may reach all other developmental milestones as expected, but their speech skills may be several months behind their same-aged peers.
So in isolated speech delay, usually all other domains, they will be normal, only they will be delayed in the speech.
There are two types of speech delays: expressive delays and receptive delays. It is possible for a child with a speech delay to have an expressive delay, receptive delay, or a mixed expressive and receptive delay. Children with expressive delays have trouble producing speech sounds.
So expressive is usually talking. So they have in producing problems in producing speech sounds.
Words, their ability to use words to communicate with others is impaired. Children with expressive delays are able to understand language, but have difficulty expressing language. Examples of children with expressive delays include a 1-year-old that cannot say at least 3 words.
Yes, 1-year-old. This is very important, whatever he is telling. 1-year-old, he should know at least 3 words. Like, anyone can tell us what a 1-year-old can speak?
Mom, dad, bye, bye.
Yeah, mama, baba, dada, something like this. Or usually this is the common. So a 1-year-old cannot say at least 3 words. This should point you maybe he is delayed.
An 18-month-old that cannot say at least 15 words.
Yes, 1.5-year-old, at least 15 words.
A
1 minute. Hello. I don't know, there's some problem maybe in that. I could not continue that, but I will post you the link in the group. Later you can watch. So let's go to other thing now. So we will go for the causes for delay in talking, which we should know. That is the speech delay, common causes, and normal speech development, which we all should know. Okay, like in that video we were speaking like 6 to 12 months, you should be able to say dada, baba, like these words. 12 months can say at least 3 words, mama, dada, baba, or other simple words. 12 to 18 months, here it's written 6 to 20 words. So 18 to 24 words. This is expressive. They should be able to say, that is 50 words. Then 2 to 3 years, 300 words. They should be, so you can remember 3 for 3. So 3 years, 300 words they should be able to say. So easy to remember, 3 years, 300 words. Okay. So here usually 2 years up to 50 words. Okay, but by 3 years they should be able to talk. This is for the expressive speech. So a 3-year-old child should be able to put 3 sentences together. Okay, sorry, 3 words together in a sentence. At least minimum should be 3. Again, you can remember 3 for 3. That is 3-word sentences minimum it is. If he says 2-word sentence like drink tea like this, it will be 2 years. He should say at least 3-word sentences. More than 3 is okay. So 3 to 6-word sentence. 4 to 5 years, 6 to 8-word sentence. So that means as the sentence should go longer. So 2 years, 2-word sentence, 3 years, at least 3-word sentence, 4 to 5 years, 6 to 8. Okay, like this. So in the expressive speech here, 12 months, only baba, dada, like 3 words. 12 to 18 months, at least 6 to 20 words, 18 months. So 2 years, 50 words, 50 words you should be able to say. 3 for 3, 3 years, 300 words. And 3 to 4 years, they should be able to say at least 3 for 3 again, 3-word sentences. 4 to 5 years, 6 to 8-word sentences. That means they will say story. 4 to 5 years will tell story. And 3 years can sing. No need for all these things. We should know the causes. What is the causes for the speech delay? So the primary causes here is primary speech and language delay. Delay is not caused by other condition. Children have normal understanding, intellect, hearing, emotional, relationship and articulation skills. That means they are normal, but they are delayed. They have no problem in hearing. They have no, their reception is good. Whatever you say, receptive language is good, intellect and emotional, everything is good, even the articulation skills, but they are delayed. Expressive language disorders needs active intervention to improve. Whoever has expressive, you should give exercises for their articulation to improve. Okay, needs active. Receptive language disorder, so it can be just primary disorder, they don't want to speak. And another is the expressive and the receptive. Then secondary, due to some problem. Then secondary is what? Due to some problems they have this, like speech and articulation difficulties. Anyone who has cleft lip or cleft palate. Okay, so speech and articulation difficulties due to cleft lip, cleft palate, or they have tongue tie, or they are a stammer, or cerebral palsy, like some neurodevelopmental cause or some local anatomical causes like cleft lip, tongue tie, okay, all these things. This is one thing, speech and articulation. Then deafness, this is due to hearing problem, deafness. Then developmental problems like familial, it can be maturational delay or environmental deprivation and neglect. Who can give example for environmental deprivation? The child is neglected. No one is there to play with him. No one is there to talk with him. Okay. This can be one of the reasons, or more than one language at home. At home, they are using something. At school, they are using something, different languages. Learning disabilities and cerebral palsy. Communication difficulties like autism, communication. They will have problems of communication. Then other is the selective mutism. The child selectively refuses to speak according to particular circumstances. Childhood apraxia and dysarthria. No need for more things. Dysarthria we know due to a problem like maybe from hemiplegia or from ataxia or something like this. So assessment. So first, before assessment, you should always think, is the child hearing normal? Is this an articulation, speech, or language problem? Is this an isolated problem or part of global delay? Like, is the speech is just isolated or the whole global developmental delay is there? Is this an isolated problem or part of more global development? Is this a communication disorder? Like, this question will answer autism. This question, global developmental delays like Down syndrome, Williams syndrome, and CP child, and all those things. Is it a problem with the expressive speech or receptive speech, like articulation problems in cleft lip, cleft palate? Okay. Or is the child hearing normal, hearing problems? So assessment of child answers these questions. Okay. So a good history, the history you have to cover is what? You have to find out whether he has problem in hearing or not. And he has receptive speech is good or not, understanding is good or not. Okay, next is, so you have to see whether it is global developmental delay or isolated. So physical and other social skills. Okay, note whether there are delays in other physical and social skills will give you the global delay. Establish whether there are abnormalities in non-verbal communications that might suggest autism, like in non-verbal communication in autism, like no eye to eye contact, he will not point to things, he will take our hands, okay, staying alone, all these things. So non-verbal communication, if there is, along with speech delay, it will give you a clue for autism. Complete developmental history, past medical history, and perinatal history. What we do in a regular history case in development, you have to take prenatal, perinatal history, past medical history, complete developmental history, and family history of deafness and language delay, and more than one language speaking in the house, and hearing history becomes very important here. Okay. And also always observation, how the child is playing and interacting with the parent. And if he's talking, note how he's talking, note any imaginative play. We say all these things we don't see in an autistic child: playing, interacting, and listening to someone talking, and imaginative play. Suppose if he is a stammer, he may have natural understanding, normal understanding, but speech to produce expression will becomes difficult. In autism, except in autism, the children will have good social interaction. So that has to be observed. Okay, autism can also be associated with delays in other developmental areas and also the language problem. So total developmental assessment is very important. So how do you assess? Ask the child simple questions about pictures or their play. Note whether they seem to understand you. Like show the picture of some dog and ask him, what is this? Is he able to answer you? Or is he able to identify or not? So examination of mouth becomes very important. Anatomical abnormalities, examine mouths and ears, exclude tongue tie. So always you should also look for cleft lip. In an isolated speech delay, look for a cleft lip, tongue tie, all these problems. So any child with speech delay, you should have to organize a formal hearing test by an audiologist. Suppose this child has normal neonatal hearing test, still if whenever you find speech delay, you will offer formal hearing test for him. If you think that there is some sort of language difficulty following your assessment, get speech and language evaluation too. Speech and language assessment is also very important. So how do you manage these patients? So management may sometimes be just explanation, simple advice, reassurance with involvement of health visitor. It depends, like how is the child progressing? You cannot do this just with everyone. Maybe he is normal, he doesn't want to speak, selective mutism, there you can give some treatment, reassurance that he will improve. However, early detection and intervention for any case, even in autism, we read the same thing. Early detection and intervention will give better outcome. Okay, so always early detection and intervention can be commonly used. However, early detection and intervention for speech delay may prevent or at least reduce educational, emotional, and social problems that may be caused. So early detection and intervention of speech delay may prevent or at least reduce their educational, emotional, and education problem becomes more important here. Okay, so their educational, emotional, and social problems that may be caused. A referral for speech therapy may be required. The effectiveness of therapy depends upon the cause of the speech delay. There is some evidence for effectiveness of interventions for expressive speech difficulties and the evidence for interventions for expressive syntax. All these things is not needed. More than everything here, multidisciplinary involvement may be required and the involvement of parents is vital. This is more important for us. And management is the dependent cause. What cause you got in the child, maybe it's cleft lip, cleft palate, tongue tie, or any neurodevelopmental problems, autism, whatever problem you got, your management will depend on the cause and associated problems such as hearing impairment. If the underlying problem is related to auditory apparatus, like if it is due to the problem inside the ear, okay, surgery is required. Children still need targeted language therapy to complete their rehabilitation. Suppose they can't hear, this is the problem. So they can't hear, they don't understand, and they don't respond to you. So you need to go for surgery. And then also till their language is improved, speech and language therapy has to be given. There is no systemic child development and behavior screening policy in place in UK. The evidence on screening for developmental delays in asymptomatic children 1 to 4 years is inconclusive. So prognosis again depends on the cause of the speech delay, and the prognosis is improved with early detection and intervention. So mainly here we should know the cause depending upon how the case goes, what the child has, and how you can help the child. Okay, so the management mainly complete examination of the child to explore the cause and to involve the multidisciplinary team approach and involve the parents also. And if there is hearing impairment, complete audiological examination. If there is problem in the auditory apparatus, you will go for the surgery. If it is autism, you have to touch the other things in autism, his social skill improvement along with it. And if it is expressive speech difficulties, you will give the speech therapy to improve their articulation. So the muscles, oromotor muscles will be improved. Exercises will be done to improve. Okay, this is about the speech delay. So if anyone has any comments, please go ahead before we end the meeting. Okay, if no comments, we will end. Thank you all.
Thank you. Thank you.